In this video, we'll discuss the breast, the pectoral region, and the posterior triangle of the neck. We'll focus our efforts first on the breast and the pectoral region. The breast is composed of mammary tissue, which is made up of glands and their associated ducts. This tissue is embedded within superficial fascia. The size and contours of the breast are dependent upon the amount of fat in the breast and the amount of secretory activity. In regards to the external anatomy of the breast, the nipple, shown here, is surrounded by a circular pigmented areola. In males and prepubescent females, the nipple comes to lie over about the fourth intercostal space. In females, the nipple can lie a little lower. And as a reminder, the nipple at the fourth intercostal space was a useful landmark for heart auscultation. Because the nipples contain smooth muscle fibers, they become erect during stimulation, such as when a baby suckles. And those same smooth muscle fibers compress the lactiferous ducts during lactation to excrete the milk product. And those lactiferous ducts have multiple openings onto the nipple. The axillary tail, also called the tail of Spence, is a small extension of breast tissue that projects toward the axilla. For clinical purposes, in order to succinctly describe the location of a cyst or a mass, for example, the breast is divided into 4 quadrants, and pathological descriptions can be further refined by using a clock face analogy. For example, let's say that a mass was identified right here on the breast. This would be in the inferomedial quadrant at the 5 o'clock position, on the right breast in this case. The tissue of a typical female breast overlies ribs 2 through 6 and extends from the lateral sternum to the mid-axillary line if you take into account the axillary tail. Notice how the breast tissue sits superficial to the pectoralis major muscle, shown here in blue. The natural plane of separation between the pectoral fascia and the breast tissue is called the retromammary space. This retromammary space is highlighted here in yellow. This is the space where breast implants are placed for breast reconstruction or augmentation. Interwoven throughout the stroma and fat of the breast are the suspensory ligaments of Cooper that attach to the overlying skin. These are thin, fibrous bands of connective tissue that help to support the breast and contribute in part to its shape and position on the anterior thoracic wall. During the normal aging process, the suspensory ligaments tend to lose their integrity, resulting in sagging of the breast tissue. The mammary gland itself has 15 to 20 lobes, which drain into lactiferous ducts, and as we said on the previous slide, those lactiferous ducts open onto the nipple. The dilations of the lactiferous ducts near the nipple are referred to as the lactiferous sinuses. These sinuses serve as reservoirs where milk accumulates during lactation. While it is uncommon for men to have enlarged breasts, it can happen, and this condition is called gynecomastia. In the bottom image, a male patient has had reconstructive surgery in order to reduce the size of his breasts. Regarding the development of the breasts, the mammary crests develop sometime within the first 7 weeks, usually around week 4, and then they disappear shortly thereafter. These thickenings of the epidermis will eventually give rise to the lactiferous ducts, the mammary tissue, and the nipples. The only remnants that remain of the mammary crests are the future nipples. On occasion, abnormal development of the breast can occur in which there are supranumerary breasts or nipples. An extra breast or nipple can develop at any location along the lines of the mammary crests. If an individual has more than 2 breasts, it is called polymastia. More common than polymastia, however, is polythelia, which is the presence of more than 2 nipples. Notice how this nipple here has developed along the line of the mammary crest. The breast tissue is supplied by small mammary branches that come from the lateral thoracic artery and from the internal thoracic artery. Notice how the lateral breast is supplied by branches from the lateral thoracic artery, coming from the axillary artery, and the medial breast is really supplied by branches of the internal thoracic artery. Likewise, the lateral breast will drain back to the axillary vein, whereas the medial breast will drain back to the subclavian vein by route of the internal thoracic vein. These mammary vessels are very tiny, so don't expect to identify these in lab. However, do conceptually know where they arise from. Regarding innervation, the breast is innervated by cutaneous nerves that come from either the intercostal nerves or from the supraclavicular nerves. The mammary branches of the intercostal nerves therefore convey sensory information from the skin of the breast, as well as sympathetic fibers to the blood vessels in the breast and to the smooth muscle of the nipple. Recognize that there are no parasympathetic fibers conveyed to the mammary gland, or to the breast tissue for that matter. This slide is extremely pertinent to breast surgeons who perform mastectomies and axillary dissections as their bread and butter cases. As you can imagine, understanding the lymphatic drainage of the breast is important because of its role in metastatic cancer. The breast is drained by 2 families of lymph nodes. The medial breast is drained by the peristernal lymph nodes that live alongside the sternum on the deep surface of the thoracic wall. Here are the peristernal nodes. Notice how the medial breast could drain across the midline to the opposite breast. The majority of the breast, however, roughly 75%, drains to a collection of 20 to 30 lymph nodes that are a part of the axillary lymph node group. The lateral half of the breast and the lateral chest wall are drained initially by the pectoral nodes of the axillary group. The pectoral nodes consist of 3 to 5 nodes and are situated around the lateral thoracic vein. They are often found at the inferior border of the pectoralis minor muscle. Rotter's lymph nodes are small interpectoral nodes located between the pectoralis major and pectoralis minor muscles. Rotter's nodes are especially important to breast surgeons because they happen to be highly susceptible to breast cancer. Subscapular lymph nodes are found along the posterior axillary wall in association with the subscapular vessels. In addition to draining the posterior axillary wall, they receive lymphatics from the back, the shoulder, and the root of the neck. They do not, however, drain the breast. Here are the subscapular lymph nodes. The humeral nodes live along the axillary vein, and they receive most of the lymphatic drainage for the upper limb. All 3 of these groups of lymph nodes, including the pectoral nodes, the subscapular nodes, and the humeral nodes, will all drain to the central nodes, which are embedded in axillary fat and live deep to the pectoralis minor muscle. Here are the central nodes. Notice how the pectoral nodes, subscapular, and humeral nodes all drain to the central group. Drainage then continues on to the apical nodes, which are the most superior nodes in the axilla. Here are the apical nodes. Lastly, the supraclavicular nodes are located above the clavicle and are associated with the lymphatic trunks. These lymphatic trunks return lymph back to the circulatory system. Surgeons refer to these nodes according to levels, based on the order in which these nodes are accessed during an axillary lymph node dissection. First level nodes are those that lie below or just lateral to the lower edge of the pectoralis minor muscle. They would include the pectoral, humeral, and subscapular nodes. Here's the border of the pec minor. So again, these nodes here would represent level 1 nodes. Level 2 nodes are deep to the pectoralis minor, and they would include both the central nodes as well as Rotter's nodes. Level 3 nodes are medial to the pectoralis minor, therefore they would include the apical nodes. Lastly, a sentinel lymph node is the first node or group of lymph nodes draining metastasized cancer cells. In a sentinel lymph node biopsy, a radiotracing dye is used to visualize the sentinel node for subsequent removal and further histopathology analysis. This helps to determine whether a mass is benign or malignant. There are a number of characteristic presentations associated with breast cancer, including skin dimpling, peau d'orange, nipple retraction, and spontaneous bloody discharge from the nipple. Peau d'orange is an edema of the skin of the breast. This condition is often associated with inflammatory breast cancer, which involves swelling of the lymphatic channels that cause the hair follicles and the ducts of the sweat glands to look like tiny dimples resembling the peel of an orange. Larger skin dimpling can result from a tumor or fibrosis of a glandular tissue. Whenever a mass places traction on the suspensory ligaments of Cooper, it causes them to shorten, thereby dimpling the skin, as you see here. And a subareolar breast mass can place traction on the lactiferous ducts, thereby causing retraction of the nipple. The most frequent form of breast cancer is ductal carcinoma, which occurs in about 2/3 of cases in postmenopausal women. Approximately 60% of all cancers found in the breast are located in the upper outer quadrant of the breast. And although uncommon, males too can certainly get breast cancer. Because part of the deep breast is drained by the intercostal veins, those veins can carry metastasized cells to the zygous system, and from there, those cells can metastasize within vertebrae, within the cranium, and even the brain because of the communication with the internal and external vertebral venous plexuses of veins. In lab, once you remove the skin and the breast tissue, you will be visualizing the anterior chest wall, which is covered by the large fan-shaped pectoralis major muscle. And as a result of your skinning, you should also be able to identify and locate the deltoid muscle over the shoulder. One of the first things you'll look for is the line of demarcation between the two muscles called the deltopectoral groove. Within this groove is a vein called the cephalic vein. The cephalic vein originates from the dorsal venous arch of the hand, and it courses along the lateral side of the forearm and the lateral side of the arm until it reaches the deltopectoral groove, where at the top of the groove it dives deep to empty into the axillary vein. And along its course, the cephalic vein is going to communicate with the median cubital vein, which happens to be a very common site for venipuncture. The pectoralis major muscle itself occupies the majority of the anterior chest wall, and it is invested by pectoral fascia. This muscle has two heads. One head is called the clavicular head, which attaches to the clavicle. The second head is called the sternocostal head, which attaches to the sternum, the costal cartilages, and the ribs. The fibers of the pectoralis major muscle form the bulk of the anterior axillary fold, as you see here. This is the front fold that you feel in your armpit. As a reminder, recall that the fibers of the pectoralis major muscle are inserting into the lateral lip of the bicipital groove. Notice how the fibers of the clavicular head twist and cross over those of the sternocostal head. This orientation of muscle fibers allows the clavicular head to flex the arm, while the sternocostal head is responsible for extending the arm. Let's do a brief demonstration. If you're sitting at a table, place your hands under the table in front of you and try to lift up on the table by flexing your arm. Notice how you can feel the contraction and the bulging of the clavicular head of the pectoralis major muscle. Now, turn your hands over so that the palms are facing in the sky, and place the back of your hand against the table. Now strongly push down on the tabletop with the back of your hand. Notice how you feel contraction and bulging of the sternocostal head of the pectoralis major muscle with your opposite hand. The orientation of these muscle fibers also permits the pectoralis major to be a powerful medial rotator and adductor of the arm, especially when the arm is abducted. To accomplish medial rotation, both the clavicular head and the sternocostal heads are working in unison. The pectoralis major muscle receives dual innervation from both the medial and lateral pectoral nerves. We'll see an image of these nerves in just a moment. Once you laterally reflect the pectoralis major muscle from its clavicular and sternocostal attachments, you'll be able to visualize the underlying pectoralis minor muscle. The pectoralis minor is a triangular-shaped muscle with the base of this inverted triangle attaching to ribs 3 through 5. The apex of this triangle attaches to the coracoid process of the scapula. Functionally, the pectoralis minor helps to stabilize the scapula and can tilt the scapula forward to allow for behind-the-back movements of the arm, like putting your hand into the sleeve of a coat, for example. If the scapula is fixed, however, the pectoralis minor can act as a muscle of inspiration by elevating the ribs. Imagine yourself swimming to the bottom of a 12-foot pool. You remain there on the bottom of the pool as long as you can until your air runs out. As you're swimming up and out of the water, what do? You arch your back, retracting your scapulae, thereby fixing the scapula. This allows for the pectoralis minor to assist in elevating the ribs for deep inspiration. Notice that surrounding the pectoralis minor muscle is something called clavipectoral fascia. This fascia blends with the axillary fascia. The pectoralis minor muscle is a very useful anatomical landmark. Just a moment ago, we saw its utility in being able to identify the various levels of lymph nodes. During dissection, you'll also use the pectoralis minor to identify the various sections of the axillary artery. Regarding the innervation of the pectoralis minor muscle, it is innervated only by the medial pectoral nerve. Here's a view of both the medial and lateral pectoral nerves. Notice how the medial pectoral nerve pierces the pectoralis minor muscle on its course to innervate the pectoralis major, whereas the lateral pectoral nerve can be found emerging along the upper border of the pectoralis minor, but only innervates the pectoralis major muscle. Let me also point out that the labeling of these nerves is not a typo. The medial pectoral nerve is in fact more lateral than the lateral pectoral nerve. So why this nomenclature? We'll recognize that the medial pectoral nerve originates from the medial cord of the brachial plexus, and the lateral pectoral nerve originates from the lateral cord of the brachial plexus. So these nerves are not named according to their relationship to one another, but rather are named according to their origin. In addition to finding and identifying these two nerves, you'll also be on the lookout for the thoracoacromial artery, shown here. The thoracoacromial artery is a small trunk that comes from the axillary artery. It can be found either at the upper border of the pectoralis minor muscle or just deep to the pectoralis minor. The thoracoacromial artery itself is a very short trunk which gives rise to 4 vessels, and these vessels are named according to their regional distributions. Remember the saying, cadavers are dead people. This saying will help you to remember the regional distribution of the branches of the thoracoacromial artery. The C in cadaver stands for the clavicular branch, shown here. It's very small. The A represents the acromial branch headed toward the acromion of the scapula. The D represents the deltoid branch heading toward the deltoid muscle. And lastly, the P represents the small pectoral branch coming down onto the pectoralis minor and even onto the pectoralis major. Now let's transition to discuss the posterior triangle of the neck and its contents. To expose the structures of the posterior triangle of the neck, you'll first need to remove the superficial investing layer of deep cervical fascia, which is considered to be the roof of the posterior triangle. The contents of the posterior triangle originate within the boundaries of the triangle, which include the posterior border of the sternocleidomastoid muscle, the upper edge of the middle one-third of the clavicle, and the leading edge of the trapezius muscle. The inferior belly of the omohyoid muscle courses obliquely through the posterior triangle of the neck, further dividing it into an occipital and omoclavicular triangle. The occipital triangle is so named because the occipital artery appears in the apex of the triangle. Also realize that the only motor nerve coursing through the occipital triangle is the spinal accessory nerve, cranial nerve number 11, which is responsible for innervating both the sternocleidomastoid muscle and the trapezius muscle. The floor of the posterior triangle is considered to be the prevertebral fascia, which encloses the underlying muscles. The muscles include the splenius capitis muscle, shown here in pink in the upper reaches of the triangle, the levator scapulae muscle, shown here in purple, along with the three scalene muscles, which are shown in various shades of green. The scalene muscles, just like the pectoralis minor muscle, can have dual actions depending on which point of attachments are stationary. For example, when the first and second ribs are fixed, the scalene muscles participate in lateral flexion of the neck. If the cervical vertebrae, however, are fixed, the scalenes can pull upward on their respective rib attachments to aid in forced inspiration. Both the anterior and middle scalenes attach to the first rib, whereas the posterior scalene reaches down to attach to rib 2. All three scalene muscles are innervated by nerves coming from the cervical plexus. Because the cervical plexus is nearby, the posterior triangle has a number of cutaneous nerves that disperse to different regions of the head and neck. What is convenient is that these cutaneous nerves tend to emerge from a localized area of the posterior triangle called Erb's point, which is encircled here by the pink dotted line. This point can be easy to find in lab because it is located at roughly the midpoint of the sternocleidomastoid muscle along its posterior border. Another way to identify Erb's point is to find the intersection of the external jugular vein as it crosses the posterior edge of the sternocleidomastoid muscle. Upon finding this intersection, Erb's point is located roughly 1 finger breadth above. Emerging from Erb's point are 4 different distributions of nerves. The lesser occipital nerve parallels the posterior border of the sternocleidomastoid muscle as it passes superiorly to supply the part of the scalp which is just above the ear and just posterior to the ear. The great auricular nerve courses superficial to the sternocleidomastoid muscle on its course toward the earlobe. The great auricular nerve supplies the skin of the lower part of the ear, and it supplies an area of skin over the angle of the mandible, as well as part of the mastoid process. The transverse cervical nerve passes anteriorly across the sternocleidomastoid muscle on its trek toward the anterior neck. This nerve will supply the skin of the anterior triangle of the neck. If you have difficulty finding the transverse cervical nerve, it is possible that it could have been reflected with the platysma muscle, so look on the deep surface of the platysma. A group of supraclavicular nerves pass inferiorly from Erb's point to innervate the skin of the shoulder, the clavicle, and even the upper breast, as you recall from an earlier slide. There are medial, intermediate, and lateral branches of these supraclavicular nerves that can be identified. If a patient is having neck surgery, regional anesthetic can be injected at several points along the posterior border of the sternocleidomastoid muscle. Erb's point is a key injection site to locally anesthetize the area. Lastly, let me point out the spinal accessory nerve, cranial nerve number 11, which is the only motor nerve passing through the posterior cervical triangle. This is a busy image, but it portrays a number of key landmarks and anatomical relationships that are pertinent to the posterior triangle. I first want to point out that the roots of the brachial plexus are emerging between the anterior scalene muscle and the middle scalene muscle. Also notice that the subclavian artery, shown here, exits between the anterior and middle scalene as well. Notice, however, that the subclavian vein is going to pass anterior to the anterior scalene muscle. The arteries that course through the posterior triangle of the neck arise from the subclavian artery via the thyrocervical trunk. To access the arteries, you'll need to reflect the sternocleidomastoid muscle superiorly after shaving it from its sternal and clavicular attachments. Here's the thyrocervical trunk, and coming from the thyrocervical trunk is the transverse cervical artery. This artery courses in the opposite direction as the transverse cervical nerve. Notice how this artery courses posteriorly toward the trapezius muscle. This artery can further divide into a superficial and deep branch. Recall that the deep branch of the transverse cervical artery is what we'll refer to as the dorsal scapular artery, which supplies the rhomboids and the levator scapulae muscle. However, here on this image, you see a true dorsal scapular artery, which is arising directly from the subclavian artery. That would suggest that this particular individual does not have a deep transverse cervical artery. The suprascapular artery is also arising from the thyrocervical trunk. This artery heads to the shoulder. It courses over top of the superior transverse scapular ligament to supply both the supraspinatus and infraspinatus muscles. Lastly, I would like to point out the veins associated with the posterior triangle of the neck. The largest vein in this region will be the external jugular vein, which is formed by the union of the posterior auricular vein with the posterior division of the retromandibular vein. Notice how the retromandibular vein follows along the posterior edge of the mandible, and it divides into an anterior division and a posterior division. Once the posterior division unites with the posterior auricular vein, it forms the external jugular vein. The external jugular vein receives a number of tributaries, including the transverse cervical vein, which drains the trapezius muscle, the suprascapular vein, draining both the supraspinatus and infraspinatus muscles, along with smaller anterior jugular veins, which drain the anterior triangle of the neck. The posterior external jugular vein usually doesn't exist, and if it does, it's really small and difficult to find. So mark that one off your list. Don't worry about it. This concludes the video. As always, happy studying.